physician. And statistically speaking, the slide that I have for this is not quite graphical as the other one was, and that's probably unfortunate, but this is what I have, and it does show some significant identified patients who receive some benefit, clinically significant drug-drug interactions, potential disease or drug episodes, and we had an opportunity for 84 patients to be redirected and medication issues identified. So we felt that these models were all being successful, and so we decided to expand this program. So the expansion of this program came first and most prominently in the scope of the pharmacist's ability to interact with the patient. The different scope that they would have would include the following: medication adherence and transition of care, which we talked about in those two smaller pilots that we had, the diabetes A1C goal, hypertension, hyperlipidemia, and they have recently expanded into pain and opioid management, high-risk medications, medication side effects, polypharmacy, and medication access. So our pharmacists have now been empowered when they sit in the medical home to be able to address all of these things. We think that this is something that is unique because sitting inside of their own pharmacy or in situations that are not directly involved with a primary care physician might not allow this to be quite as effective. So the scope of our program has increased to all of these. We feel that there's a significant benefit when the pharmacist and physician sit face-to-face with the patient or immediately after the patient, allowing this broader scope for the pharmacist. The expansion of this program also included the pharmacist's work. The PharmDs are now using lists to find patients, and so they're actually going out and finding these people beforehand. On a personal note, it was more than once that the pharmacist came to me and said, "Your next patient that you see really belongs with me as well. Will you please refer them to me after you're done?" And I thought, actually, yes, I will. I'd be more than happy to have that because I know the list that's going to come out that will not involve these things that are so critical to me, but are so important to the patient. And as I try and address those for the patient, my time with some of these things are going to be limited. I would be so pleased to send this patient to you. I would say to Joanna, my pharmacist. We also expanded geographically, and so we now have 7 PharmDs that are full-time in primary care clinics. We have 2 PharmDs that are part-time in primary care clinics, and those 2 are also part-time in the pharmacy. We've expanded to 15 clinics. We're covering about 100 practitioners now and about 150,000 lives with our pharmacists in the medical home. And this year we've got FTEs to add 4 more PharmDs into our program. So I'd like to tell you about a few of the details of this Collaborative Pharmacist Support Services program at Intermountain Healthcare. So these details include, I don't know that I need to go through each one of these, but let me suggest that some of as I talked with the pharmacists, what would be important for people to know if they want to implement a program like this? And one of the ones that's so important is the money. You know, where do the FTEs come from? And I'll address that in a slide in just a minute. But the second one was the understanding that the pharmacist really needed some support from the entire team. They weren't just simply placed in the pharmacist and said, "Go do your usual care, good luck to you." But if really we're integrating the pharmacist into our clinical care team, do they get medical assistance support for blood pressures, etc.? Do they get PSR support for scheduling? Can they go to those patient service representatives and say, "Will you modify my schedule? Will you change this? Will you help me with this?" Were they truly a part of the team? And that was where they said was the most important feature that they would like people to know in this is, if you're going to do this, make sure that they have adequate place in the team to be able to integrate, but also employ or use all the different parts of the team. We also talked about how referrals come, and we've expanded that, of course, to from the care managers who take our diabetes bundle list and our hypertension lists and refer those people to the pharmacist, but also now we've expanded so that the practitioners are very well aware of the pharmacist who's sitting 2 desks down and how to interact. And we've had great success. Without numbers, we've had great success with our practitioners welcoming and interacting with our pharmacists. Face-to-face visits come initially, but sometimes intermittently. They do like those face-to-face, but they do a lot of phone work as well, and that phone work is very appreciated by the patients. They follow the collaborative practice agreement. So that is one particular that would be important to know as we integrated this, that we needed to give some direction to the pharmacists. As we increase their scope of practice, what does it look like? How are they actually working with the physicians and not just out on their own in deciding what kind of medications they can prescribe, medications that they can change, what can they do with the opioids if that's what they're working with. And so we've had in our collaborative practice agreement, within Intermountain we have our clinical programs that make a care process model. This care process model is fairly comprehensive for our different entities, including the diabetes care process model, the hypertension care process model, chronic kidney disease, opioid, and all these kinds of care process models that allow that communication with the pharmacist and help them to know what is their scope. And then the physicians also know exactly what is their scope to be able to practice. So having that care process model in place is very critical. And so I've brought a slide of the collaborative pharmacist support model that is also the guide for the pharmacists. And it's got 2 pages here, and without going through all the details of it, it is well structured. And what I didn't bring was the 47-page care process model for diabetes and the 27 care process model for kidney disease. But those are all within the practice for our pharmacists so that they have that guiding direction of what they can do, and we're all on the same page. Yeah, here we go. Okay, so we did a research study on this to say, is this being effective? Are we actually reaching our goals? Is it clearly we actually don't have goals and measurements, which I wish we did, about provider satisfaction, pharmacist satisfaction, and patient satisfaction. And we just simply didn't get that, and that would be lovely to present to you. So anecdotally, we haven't talked to anyone who's any less than thrilled, but statistically speaking, we wonder what is happening with this. Are people achieving their goals? So our patient goals were the established goals of blood pressure less than 140/90 and A1C less than 8. And then we also had 2 other goals that we measured in this study: time to reach the goal and the number of encounters with the team. So we have data here that shows that this collaborative pharmacy support service did reach goals that were measurable, and these A1C and blood pressure targets were all met here, and you can see the p-values are all right of the line. We also have the time to reach control was improved, and the numbers here, the lines deviate fairly quickly, and the p-value is less than 0.001 for time to reach goal. And then a very small portion over here was the 3rd goal, significantly more visits with the care team overall, and that includes phone calls, and all the different practitioners had 8.0 visits versus 5.1 visits per year. And these were all successes of this program. So we think that we've modeled something, and we're carrying forward a program to have the pharmacists integrated into our medical home in a very unique and personal way. We've found success with that, and we're going to increase and continue to increase the program. I did put up a few things that I think are very important to make this program work. I think these are the things that we're all familiar with, we know about, and we're trying to implement most appropriately within this group. These things all help us to be able to make this program successful. Without the advances in the last decades in healthcare, we wouldn't be able to do this, but we think that this is the time and that it's a successful program to integrate pharmacists into our medical home. So that's my summary. Thank you.
And our final presenter is Dr. Phil Oravetz from the Oschner Clinic in New Orleans.
And now for something completely different. So first, by way of correction, I'd say my career has paralleled Jerry's. I left California 6 years ago as well, after 24 years. And people ask me, how could you leave California for New Orleans? And by the measure of how many San Franciscans live in my neighborhood in the Garden District, it's not very hard, right? They're coming there in droves right now, like I did. So I left 6 years ago. I do all the pop health and risk business, and there's a heck of a lot in our system. So we're going to talk a little bit different about some of the stuff that's coming out of our innovation center. And really, I'm here to challenge us all in the management of chronic disease. And the first thing I do is hold this up and say, this is the most powerful piece of medical technology that you will ever adapt to manage chronic disease. Okay? And so interesting, we're the largest, I'll move on, we're the largest private employer in the state, and the biggest group of our employees are millennials. And you know, for you who have kids, this is the only way you get through to them. Like, they live on these things. And I would ask, who in this room hasn't looked at their smartphone in the time they've been here, since they came in this morning? What huge opportunities to manage chronic disease better and interact with our patients. So we're going to show you some of the work we're up to. I think we're on to something. Okay, we're early, we're getting good results. It's one thing to make it successful in our innovation center. Throwing it over the fence to me in pop health is a whole different animal. But I think we're on to something. So just, you know, briefly, I'll just talk about Oschner a little bit. Pre-Katrina, which is still how everything is dated in that part of the country, Oschner had one hospital. So they've been, and that was in 2005. It's been a period of torrid growth. We now have 30 affiliated, owned and affiliated hospitals. And in fact, we now have the largest multi-specialty group practice, over 1,200 clinicians, and we have wraparound clinical integration networks. And so we're statewide right now. And what's interesting is that our million, right, we now impact 1 million of the state's residents, a quarter of the state's population. The reason this is significant, you know, when you see some of the national graphs, Louisiana is absolutely dead 50th in terms of the health status of our citizens. So you think you got diabetes problems and obesity and hypertension. We are dead last. And in fact, our moonshot is, you know, by 2025, we want to be out of the 40s. You know, that's our goal. It's crazy. And so I talked about, you know, we do just about everything. We have our own medical school, but we're going to talk about our innovation center. And the first thing we're going to talk about is our OBarr. And I love the tagline of our OBarr: serving up technology that keeps patients engaged and out of the doctor's office. As we move further and further into value-based care, I believe I can manage your chronic disease better by having you never come to the doctor. How's that for like a totally different, right? And I get where you're, you know, look, we're still very much, we're right at the tipping point to value-based care. Hey, I got departments that live and die by RVUs, just like you all do and your community docs do. We got to do away with this, right? So this is what our OBarr is up to, okay? And what we talk about amongst the tens of thousands of apps, right? There's lots of things that the internet's good for, and having apps is out there. We kind of have vetted those apps. Now, one of the best kept secrets, I can't even get a list of the apps. Our innovation center kind of has this as a well-kept secret, but they run about 400 apps. So they've taken everything out there, and they vetted about 400 apps that will actually serve up to the patients. And we do that through something called our OBarr. Now, y'all probably are very familiar with Apple stores, right? You go to the Genius Bar, you make an appointment, and you go to the Genius Bar, you just show up, and lo and behold, like, you know, my smartphone doesn't work, my iPad doesn't work, they fix it, okay? And indeed, here are some photographs of our OBarrs. Okay, so this has gotten a lot of press over the last 3 or 4 years. We now have 5 of these. We'll talk about what they are. And you see our guy there who's actually, he's not a medical person, he's a techie person. And one of the fascinating things I would, if you come to New Orleans, come by and just sit at the OBarr for an hour. So this is kind of the key to our digital programs that I'm going to just show you, our digital diabetes program. We have, so we're in digital hypertension, we're in digital diabetes. I'm going to highlight the model of that today. But you sit there for half an hour, a patient comes up and says, my doctor referred me to digital diabetes or digital hypertension. The patient sits down, they get their blood pressure cuff, and this techie person actually hooks them up. So we're one of the group, we have the distinction of being the first group in the country to integrate Apple's Health Watch into Epic. We're one of the big development shops for Epic. And within 30 minutes, the patient can take their blood pressure. I see it go through their smartphone and show up in their Epic electronic health record. 20 minutes. So we're not just telling the patient, here's some instructions, let me know how it goes. We actually show them how to do it, and they walk out of there. You don't have to know anything about technology, and we're managing your blood pressure, okay? And so you heard earlier about, the usual care is usually getting your blood pressure taken 3 or 4 times a year at the doctor. Through our digital hypertension program, it's 3 or 4 times a week. So imagine that we're now feeding hundreds of blood pressure measurements into the system. We're starting to turn on artificial intelligence to allow that, look at trends and patterns. So that's our OBarr. So we talk about they're attached to our primary care clinics, so patients can just pop in, but increasingly, we are, hooking up all the things, right? So if your doc says, go get a Fitbit, you can come and get it. Right now we're into digital diabetes, so you're getting your glucometer, blood pressure cuffs, we're hooking all this stuff up, and our primary care docs write prescriptions for this stuff, right? We're trying to engage the patients in their own care, because we know they're looking at this thing hundreds of times a day. Hundreds of times a day. What a huge opportunity. And when we talk about disruption, what keeps me up at night when I read about, all the Googles and Amazon, everybody getting into healthcare, if you don't think they're going to do this, they don't think anything of it. And we're still just struggling along with come to the doctor. Don't come to the doctor. So we write prescriptions for this stuff, and it just rolls. And we've, like I say, we now have 5 of them, and we're going to keep rolling them out, right? So we can talk a little bit after OBarr. Let's talk about our digital diabetes program. And again, this is parallel. It's really just as a common model for how we're thinking about managing chronic disease, right? And the first thing is, I don't want you coming to the doctor. That's our first thing. Your doctor has nothing to do with managing your chronic disease. In fact, they do an awful job of it, as evidenced by all the results that I've seen today. We're not getting it done. If there's one takeaway, this is your takeaway slide. So here on the left is our traditional model, which is what's getting us what we're getting today. And on the right is this whole new concept of multiple feedback loops, literally infinite amounts of data. I can track everything about you. If you think Facebook doesn't track everything about you, why aren't I doing the same? I want to know what you eat. I want to know how you sleep. I want to know, are you exercising? And now I'm going to just prompt you to do all this other new stuff. This concept isn't a new concept. It's called an integrated practice unit. And I don't know who actually initially wrote about it, but where we're picking it up is, if you want to me, the reference is Michael Porter out of Harvard Business School, right? Has really written a lot about integrated practice unit. And the idea is, right, frequent data points. We're running analytics, social networks. This is where we're understanding that, the zip code you live in probably is more important than your physician to your health status. Ugh, scary stuff for those of us who went to medical school. So that right-hand slide is probably the most important thing, right? So we provide patient-centered care, collaborative teams, and you're going to see how this all does come together now. But it's empowering patients. This, to me, is the ultimate patient engagement tool. We're empowering patients to manage their own care, right? They're the only ones who can do this, not us. And it's more about, and it really gets down to how do we change their behavior. So, right, everyone has treatment goals in diabetes. Yep, I'm going to go. How can we make it easier? Right, we have goals. But now our strategy is, we too, in our integrated practice unit, are not using clinicians, we're using PharmDs and health coaches. Okay, we're using, that's kind of the core of our integrated practice unit. And then everything is sent to the digital medicine team real time. As soon as it happens, I know about it. I'm not waiting for a medical claim to show up 90 days later. I'm not waiting for even a lab result to come back. As soon as that resulted, my team knows about it, right? So our eligibility to pay for this today, we're really limiting it to our risk-based patients to get some funding going. We're working on how that works. They have to have a smartphone. We're not going to give them a phone today. And then the providers, the providers all work under a collaborative practice agreement. Lots of enrollment. Here's our process for enrollment. You got to have a portal account as well, because that's one of the keys. We use our portal for everything. Like, that's the main communication tool. But I do talk about this intake questionnaires. Yeah. Oh my God, when's the last time your doctor asked you all these things and actually collected all this data and digitally and put it in? And we're not turning AI on this because every patient's different, right? And access to care, transportation, health literacy. This is the ultimate patient activation tool. I now know. So we're collecting lots and lots of data. My doctor never asked me about any of these things. How could they in a 15-minute visit, right? How could they? So we're collecting lots of data. Basically, storing data is free. It's infinite and free. And computing power is infinite and essentially free. Okay, real-time analysis. So here's one of my PharmDs who's sitting at their little Apple product. And we do talk about this is, I know you heard earlier about stratification, absolutely key. And where we're applying this today, just like you heard from the other groups, in hypertension, we went after the people who the primary care doctors couldn't control. Send us your worst of your worst. And lo and behold, 6 months later, they get sent back and under control. It's like, actually, that's very motivating for our primary care docs, because they're really frustrated with these people they can't control, and now they have an out. And it motivates them to say, okay, I can probably do a little better. Maybe I should send less patients there. We're doing the same with diabetes, right? The worst of the worst. And the primary care docs love it. Refer these patients in. Because every primary care doc who I've ever met has 10% of their diabetic panel that they can't get under control. They just can't do it. This program does it. Okay? So we have education videos that we work on with them. And then we give them these monthly feedback. We use a lot of behavioral economic research. The most important thing that I can send a patient is in a smiley face emoji when their blood pressure is under control. It actually scares me how simple it is. You send your blood pressures in, smiley face emoji that says, you're doing a great job, keep it up. Isn't that the feedback that we all want? Right? You're doing a good job, keep it up. Yay, motivate me. Right? So we're giving them feedback. And a little bit more about our program, right? Manage diabetes on your schedule. However you want to live your life, we'll make sure that your diabetes is under control. Okay, so here's our brochure. And then, as I say, all the things that we have, signing up, provider preferences. The providers, early on we had a couple primary care docs that said, I can't do this. Oh my God, no, I'm the doctor. And now I don't have a single primary care doc who isn't signed up. Because once they understand the power of this to help them manage their patients, we really roll. Okay, so I promised that we'd have time for Q&A, so bring it on, because really I think we're on to something. I would say in our hypertension program, just to give you scaling, the first 2,000 patients are through it. We're getting 80% control rates. That's wonderful. My hypertension registry in Epic has 150,000 patients. Right? So, okay, my diabetes program, the first 100 patients are on. Attached to my primary care docs, I got 35,000 diabetics, right? So innovation is one thing. I think we're on to something. Throwing it over the fence to me and Pop Health, I've got a scaling, I'll be upfront. Scaling's a huge issue. But the principles, the core principles really work, and I think we're on to something. We'll talk about
So thanks so much to the three presenters, Dr. Averbeck, Jones, and Oravetz. Can we all give them another round of applause, please? Thank you. So now that you've heard these great practices and strategies for improving diabetes care, I wanted to gauge the audience in terms of the feasibility of your organizations adopting these or promoting these strategies. So the first question I have for you is, which diabetes care management strategy is most operationally feasible for your organization or practice partners? The CV Wizard for decision support that the HealthPartners group discussed, the echo video consultations between specialist endocrinologists and diabetes health educators and PCPs for case-based learning, pharmacists embedded on the care team, as was discussed by Dr. Jones at Intermountain, and then finally OBarr, this digital app genius bar for patients for diabetes and hypertension management. So which one would be more operationally feasible for your organization partners? All right, we're going to stop at 50. I think. Which one? There we go. So pharmacists on the care team seems to be the most operationally feasible strategy. And we heard two different approaches to using pharmacists on the care team. It seems like one was an embedded model and the other one was shared between multiple practice sites. And so one thing I was curious if you could elaborate, Dr. Averbeck, is how the non-embedded model would work given the limitations noted by Intermountain.
Sure, and then for us it would be sort of embedded on a rotating basis, if you will, and so some of the sites that have got a number of clinicians might have a pharmacist that's on site full-time. Others, since we have a couple of clinics where there might only be one, the patients might need to travel to a neighboring clinic, but we've tried to geographically have them available. But a few of our sites in western Wisconsin or one that's in northern part of Minnesota, that's where we use a televideo, so then they just use the televideo for one that's stationed at one of our clinics.
Thank you. So I noticed you all voted, a few of you voted for the technology-intensive interventions, and I wanted to open it up for discussion as to what is the hesitation here. Is it that there's not enough evidence for you to be excited about pushing these, or is it that some other reason, complexity or not my patients, that sort of thing? I'd love audience participation. Liz? No. So it's most operationally feasible. So I'm being mean and forcing you to make a priority here. But
the comment I want to make is early days, right, when we started talking about pharmacists on the care team, zip. So to see where we started, well, right care 10 years ago, where we started with Chronic Care Coalition 9 years ago, started talking about that, to see where it is today. Congratulations, because I think we're totally moving in the right direction and we're going to see amazing results.
Right.
Agreed.
Others?
Agreed.
Yes.
I'm Martha Brody. I work for HealthPartners, but my background is I grew up down to part of HealthPartners. And I think with digital medicine, our aging population is not ready to handle the sophistication of digital anything. A lot of times, my dad's 87 years old. He's got all kinds of cardiac issues, and he wouldn't be able to figure it out on the smartphone. It's the same thing with the Medi-Cal population. You have to have more hand-holding, more coaching, more navigation, and more interpersonal. That's what I found in my diverse ethnic communities that I've served.
Yeah, I would just respond to that. We had those same perceptions, and our data doesn't bear that out. No, our data does not bear that out. That senior populations can use this technology the same as everyone else.
So we have a question in the back.
I think I would completely agree with the fact that aging and technology, I was a non-believer until I did a hypertension study using an app. And my 85-year-olds were more engaged and better at it, although the only thing they sometimes ask me is, can we just